Hello, everyone. I see attendees jumping in. It's nice to see everyone. By way of introduction, I'm Krystina Lewis, and I am joining you all here today in my capacity as the lead of the Knowledge Mobilization Crosscutter of the Brain-Heart Interconnectome. And I'm really excited to see many people joining here as we get started. So thanks for joining us. For audience members who are joining a BHI event for the first time and who may not yet be familiar with the program, the Brain-Heart Interconnectome, or BHI, is a robust interdisciplinary research program funded by the Canada First Research Excellence Fund that is seeking to improve the diagnosis, the treatment, and prevention of concurrent brain, heart, mind conditions, and aspiring to evolve into this new field of study. Le webinaire d'aujourd'hui se déroulera en anglais, mais tout de même, je tiens à souligner notre engagement en faveur du bilinguisme et à rendre hommage à la nation algonquine sur les terres ancestrales de laquelle se trouve l'Université d'Ottawa, d'où j'ai le privilège de vous joindre aujourd'hui. Nous reconnaissons le lien sacré de longue date l'unissant ce territoire qui demeure non cédé. Nous rendons également hommage à toutes les personnes autochtones qui habitent à Ottawa, qui sont impliquées dans l'Interconnectome cœur-cerveau, qui sont parmi nous aujourd'hui, qu'elles soient de la région ou d'ailleurs au Canada. Nous reconnaissons les gardiennes et les gardiens de savoirs traditionnels de tout âge, d'hier, d'aujourd'hui et de demain, au courage indéniable. And so today's 1-hour webinar intends to serve as a primer to co-production of research with knowledge users. And so since its conception, a co-production approach has guided the BHI and has shaped the very direction of the program. And so by its very nature, the BHI requires engaging diverse perspectives, including researchers, specialists in brain, heart, mind, health, and knowledge users, including our Indigenous partners, patient, consumer partners, clinicians, community groups, government, policymakers, and industry partners. And these knowledge users are individuals who are well positioned to use the discoveries and the research results that arise from the BHI to make decisions about clinical practice, about the design and implementation, about new programs, and also health policy. And so we'll begin today with a presentation and a conversation with Professor Anita Kothari, who's professor in the School of Health Studies at Western University, who will offer an introduction to what co-production is in health research. And then we'll follow with a conversation with knowledge users who have ample experience being and having this role on funded brain and or heart health research projects. And so we'll have the chance to speak with Karen Padilla from the Global Heart Hub and Patrice Lindsay from the Heart and Stroke. Just a bit of housekeeping before we get started. Please note that this webinar is being recorded and will be made available online on the BHI website after the event. I would also invite everyone just to ensure that their microphones are turned off just to minimize any background noise or echoes. And also, please note, we've reserved a few minutes at the end of the webinar to take questions from you. And so I'd invite you to share any of your questions in the Q&A, and it would be my pleasure to bring them to our panelists at the end, or at the time that we have reserved at the end. And so with that, it is my pleasure to hand it over to Anita for her presentation.
Thank you. I'm just getting set up here. And okay, so you can see the screen there, everyone?
Yes, yep, we can see your screen.
Beautiful. Good morning, everyone. My name is Anita Kothari, and I'm in the School of Health Studies at Western University. And I'm so thrilled to be here to be talking about research co-production with knowledge users. Before we begin, I just do want to acknowledge that I've been working with Ian Graham and Chris McCutcheon for a number of years now on this topic. And so a lot of our ideas have developed together, and we've worked on many things together. So I wanted to make that an acknowledgement before I move into the presentation. So what I'm going to be talking about today very quickly, because we want to spend more time on the Q&A, is what is research co-production, what is its value and potential impact, And then what kinds of strategies and tools are out there for you in case you want to move into this area? So just to begin, research co-production is a model of collaborative research that explicitly responds to knowledge user needs in order to produce research findings that are useful, usable, and used. And the research co-production is essentially responding to the problem that research isn't being used in health services and policies. And it does share roots with other partnered research approaches like action research or participatory research. But one of the differences is that with research co-production, knowledge users are involved as part of the research team with equal decision-making power as the researchers on the team. The goal is not necessarily trying to empower the partner, but really we're working in partnership, equal partnership. And that means that knowledge users are also making decisions about the research question, the research design, data collection. Maybe they're involved in data collection, definitely involved in data interpretation, disseminating the results, and implementing them. But I haven't actually told you yet who a knowledge user is. And I think that's important for this conversation and to make sure we're all on the same page. So knowledge users are those who can use research findings to make healthcare system decisions. So if you look on the left-hand side, the blue side of that figure, you can see that the research team is made up of researchers and knowledge user partners, right? It's that equal decision making. But there are other individuals out there in the research ecosystem, right? There are other stakeholders who might actually be interested in the research findings, or they might be affected by the research findings. They're represented there in the green panel. Perhaps you have an advisory panel that you turn to in your research process from time to time. Perhaps there's a steering committee, or there are other interested parties like funders, for example. But this group of stakeholders is not involved in the actual process of research, unlike knowledge user partners. And then, of course, there's broader stakeholder engagement. You might want to get broader input with respect to the research, and that might be at the end of the research. That's very traditional, where you disseminate your research to those who might be interested in the findings. Or maybe through the research process, you might have a workshop with broader stakeholder input, again, by groups who might be affected by the research findings. So quickly, what is the value of co-production and its potential impact? So I was involved in some work led by Catherine Sibley, and what we did was we did a rapid review of 9 reviews of research co-production. And from that review, we really we identified 7 categories of benefits of co-production. So the value of co-production can be found, if I look at number 1, the research process itself, right? We saw in the literature that priority setting was influenced. We noticed that projects that were planned in a co-production way were more likely to receive funding, for example. Then if we move on to number 2, we also realized that we saw in the literature that there were the benefits to the actual relationship among the team. So there was enhanced communication. There was an ongoing relationship between the project in some cases. There was ongoing trust that was built. And even beyond the team itself, when we look at number 3, the actual individuals involved in co-production benefited. So there was some knowledge that was gained. There were skills, perhaps skills about how to do research, or skills in terms of how to understand the policy process. So that also showed up in the literature. Other benefits to research co-production, of course, if we look at number 4, they influence the output of the research. So, of course, the research itself is more relevant because we've got questions. The research questions come from the field, so to speak, come from health services, the service, or they come from the community. But if they're generated through a research co-production team, they may carry with them some increased authenticity. And when these research findings are used, if we move to number 5, they're influencing service delivery. They could influence practice recommendations. So there were some benefits in terms of practices and programs. And then moving on, there are benefits in terms of the community. If we're looking at broader impacts, greater community trust, for example, communities valuing research in a way they never did before. And then we also saw benefits in terms of policies and systems. So then the last question that I was asked to address was what kind of strategies and tools are available? And so I'm going to name just a few of them. So there are a couple of very good review articles that talk about some guiding principles. So IKT, I should just say, is integrated knowledge translation, which for the purposes of this presentation will be is equivalent to co-production. And there are some evidence-based guiding principles out there to help you if you decide that you want to embark on a co-production project. And I don't think these principles are going to be any surprise to you. There is also a book that was edited by myself, Ian Graham, Joe Rycroft Malone, and Chris McCutcheon. There's 16 chapters. You can buy a hard copy, or your library will probably have an electronic copy. There's a lot of gray literature out there. This is a gray literature document that I like to, it is Campbell and all, I like to refer to when I'm writing a proposal about co-production. So there's a lot of gray literature out there about co-production. And then finally, sometimes we like to know where we're going to end up before we start our process. So then in that case, I would direct you to, there are evaluation frameworks like this one. This is RQ Plus Co Pro that Rob McLean led from IDRC, and it's really a way to measure research co-production. But if you have a look at it, and there's a website there, if you have a look at it, you have a better understanding of what kind of indicators might be put in place beforehand so that you move forward with a rigorous kind of process. And then, of course, I would be remiss if I didn't suggest the Integrated Knowledge Translation Research Network. If you just go there, and there's a lot of resources there that I hope will help you, along with CIHR. The CIHR website includes worksheets, and it includes a lot of text around integrated knowledge translation or research co-production, as well as examples. So thank you. And if there are any immediate questions, Krystina, I don't know if we want to take them now or later.
Perhaps we can take them later. And so if I would just ask audience members to hold their questions or to insert them in the Q&A, and Anita will return on the panel once we have a chance to have a conversation with our other panelists. Thank you so much, Anita, for this presentation. It really offers a good foundation for what it is we are talking about today as well. And I also wanted to note that the tools and the resources that you have mentioned, we will include in show notes as well, and will be included with the webinar recording. And so we'll forward that onwards to our audience members as well. So thank you. I'm now very excited to hand it over to Karen Padilla, who is the Global Heart Hub's Heart Valve Disease Council lead. Originally from Guatemala, Karen is now based in Dublin in Ireland, and her background is in marketing and in the pharmaceutical industry, and now passionate about international patient engagement. And the Global Heart Hub is an alliance of cardiac patient organizations that aims to create a unified voice for people with or who are affected by heart disease to advocate for the best possible outcomes. And so Karen will start by describing to us a project on which she is a knowledge user on really an exemplary co-produced endeavor. And then we'll hear more just about co-production and how it can be done from that knowledge user perspective. So Karen, I'll hand it over to you to share us your project.
Thank you so much, Krystina. It's a pleasure to be here with you today, and thank you so much again for the invitation. And I must say, before I start, a huge congratulations on this great initiative on the BHI. I'm really looking forward to learning more about all the research and all the outcomes that you will have in the coming years. So while Ellie's pulling up my slide there, I just wanted to also start by sharing with you a little bit about my organization, Global Heart Hub. So we have a global community of roughly 130 patient organizations from 42 countries. And I really have the honor of leading the Heart Valve Disease Council, comprising 24 patient organizations from 19 countries. So you can imagine it's quite a varied and like diverse group. The council is really a platform for heart patient organizations working in heart valve disease to share their views, learn from each other's best practice, unite on common goals, and share resources. And the council also advocates for improving equality and access to treatment across the globe. And one of the key areas that the council has identified as a priority is shared decision making. So for those of you working in the field of cardiovascular disease, you may know that shared decision making was recommended within the heart valve disease clinical practice guidelines just at the beginning of the decade. However, uptake into routine practice has been very slow, and too often shared decision making does not take place. So because of that, we as the Heart Valve Disease Council saw the opportunity to gather group of experts and create a round table that was in August last year to really try to tackle this issue and see from all the different perspectives what can be done to make shared decision making a reality. So this group of experts was very unique. It was actually representing patient advocates and heart team stakeholders. So we had cardiac surgeons, interventional cardiologists, general cardiologists, nurses, of course, patients, patient organization representatives, carers. So really to bring together, and researchers, of course, to bring all the angles and all the perspectives together. And the objective was to develop a consensus roadmap to accelerate advocacy in different countries and settings to really make sure decision-making a reality. So the puzzle pieces that you see on your screen summarize the local and the global actions recommended in the roadmap. And I invite you to scan the QR code to learn more about the project. So as Krystina mentioned, today I wanted to start my intervention by presenting an overview of this project, as I think there are some valuable learnings that I can share with you. For example, I think one of the key learnings, and something that we also as a global or umbrella organization learned and wanted to keep doing, is that this event was co-chaired by a patient and a clinician. And this was really key to ensure that the patient voice was seen as an equal stakeholder in the discussion. And also before the meeting, our knowledge partner, the Health Policy Partnership, conducted one-to-one interviews with each participant. And this was to ensure that their perspectives were included in the pre-read for the meeting. And maybe a third point, and then we can discuss more about it, Krystina, because I know that you are also a co-author of the roadmap, so we can also go a little bit deeper into the project. So once the roadmap was launched, the patient organizations that are part of the councils received a toolkit with all the information so that they could replicate this model at a national level and really advocate with their national authorities and even some of them, I have the example from Spain, for example, they replicated this same model and gathered a group of clinicians, patients, family members, and government at a round table to discuss this roadmap and see what really made sense for them in the Spanish context, what key aspects they could take to create a model that really worked for them. And now they are also implementing that in Spain. So thank you very much for sharing my slide. We can stop the screen share, and I'm happy to discuss further with you, Krystina.
Sure. Thank you so much, Karen, for sharing a glimpse into this co-produced endeavor. The first question that I had for you, Karen, is to start off a bit broader. And so, as you well know, patient and public engagement approaches are gaining traction, and this is also a requirement within the BHI to co-produce with knowledge users and also with and partner with patients on the projects. And so as these requirements for funding agencies and funding groups increase, what do you, the Global Heart Hub, and yourself consider when research teams or other organizations are reaching out to you with a proposal for collaboration?
That's an excellent question, Krystina. Thank you for that, because I think it's also very important, of course, apart from all the usual aspects, like in terms of compliance, like whether the project is funded by multi-industry and, like to make sure that all stakeholders are considered for a project. For us, it's really important that the patient voice is included from the outset as an equal stakeholder. So the way that the project is presented, we are really keen to understand how the input from patients or carers is expected to be provided at what stage, and also what the outcomes will be. Unfortunately, sometimes it still seems to be more like a transactional aspect of having patients involved, and that's just a box to tick. But we are seeing that this is a cultural shift. This is really improving and changing, and we think that we as a global alliance can really also play a role in making sure that this is the way that the patient voice is represented and that they are having an equal voice.
Yes, absolutely. And are there certain aspects that you look for, certain tangible actions or ways in which the team is articulating the way that patient voice is coming through that is helpful to you when you're making those decisions?
Absolutely. Yeah, the more information we can have and the clearer those the process is in terms of what is expected from patients when like it's really like going back to the SMART model of presenting a project and really understanding how the patient voice will be used and how their comments and ideas will be integrated in the process. Again, just to really understand and for the patients to see how their impact is going to be taken on board for a specific project. Some of our patients might also be interested, for example, in being included as co-authors of a paper. Some of them might be interested in speaking at some of the conferences and really representing the patient voice. So I think that's also something that depends on the research project that you are presenting, but certainly bringing those ideas and that framework and letting your stakeholders, in this case, if they're patient organizations or patients, know what is required from them. That clarity, I think that's key for any proposal.
Great, that's great. So when you were introducing your project, Karen, you talked about the roundtable, that you brought all of these experts together, and so I'd like to ask you, in terms of leaving our audience members with tangible actions and what is required to make that happen. And so, what type of preparatory work that was required ahead of bringing an entire team together of researchers, of clinicians, of patient partners, and knowledge users. So what was required? What do you need to think about ahead of bringing all those people together?
That's an excellent question. And I think, first of all, and I'm talking now also from my marketing background, I think the first thing that you really need to do is just scope the project and identify all the stakeholders that you want to be involved in that project. And once you have that, one aspect that is very helpful as well is to identify some champions from each of those stakeholder groups, people who you think that could be very influential or who are also supporting the project or the ask or the aspect that you want to work with. And once you have identified them, really also ask for their help to identify more people within their network. I really think that networking helps a lot when you are in the early stages of a project, also to identify different perspectives, different experts, and also, from different countries and different backgrounds. So I would say that's one thing that really, for that specific project that we were discussing earlier, helped a huge amount, and it's still one of the great learnings that we have had. The other aspect, of course, in terms of diversity and the preparatory work that we needed to do for these specific project, is also to bear in mind all the cultural differences, including language. And going back to what I was mentioning at the end of the presentation about really giving these tools to our affiliates to localize the roadmap rather than just translating it into another language, for example. That's also very important and needs to be taken into consideration. And the earlier that you think of these aspects which will make a difference, the better. And then, of course, when you have different stakeholders at the table, you will potentially also have different expectations, and you will also have different expertise at the table. So I think, first of all, also having that time to set the scene and to make sure that everyone is talking the same language and creating a common framework so that everyone can feel comfortable to share their expertise and feel heard. And at the same time, managing the expectations, and I suppose not making assumptions, really asking questions. I think there's nothing like oversharing information when it comes to starting a project, especially when you have patients and researchers and clinicians really asking for feedback. And I think one of the key aspects as well is to ask your participants for their needs and their ideas to co-create the session. And sometimes these things can be as simple as, for example, if you're working with neurodivergent people, they might need to have a space to relax during the meeting, or even, in terms of food requirements, if someone is on, let's say, a vitamin K antagonist, you might not want to have, like green things on the menu. Or you might want to have paper cups for people with Parkinson or Tourette's. If you are talking with a diverse, geographically diverse a group, or like you have different cultures, maybe having a praying room would be also something culturally sensitive. So those little things that can also make people feel more comfortable, and in the end, like it's we're talking to people, and when we're talking to patients, they have a wealth of knowledge, and they have a wealth of experience that they are willing to share. So the more we can do also to enable that to be a pleasant and comfortable experience, I think the better.
Absolutely. Wonderful. Well, thank you so much, Karen. You've really offered some great tangible ways in which can bring people with these various backgrounds and expertise and needs as well. And I liked what you said about not making any assumptions and asking questions about what those needs may be. So thank you very much. Next up on our panel is Patrice Lindsay, a PhD prepared nurse who is currently the lead for the Canadian Stroke Best Practice Guidelines and Engagement of People with Lived Experience strategy at the Heart and Stroke Foundation of Canada. Dr. Lindsay leads strategic directions for health system designs and change, and develops innovative knowledge translation and implementation initiatives that bridge, that integrate, that support the needs and interests of people who are living with stroke and their families. She is the senior editor for the Canadian Stroke Best Practice Guidelines and Performance Measurement Standard, and has led stroke system change in Canada for over 20 years. She's involved in several research initiatives in stroke and heart and vascular cognitive impairment, with a special interest in women's heart and brain health. She is the recent recipient of the Queen Elizabeth II Diamond Jubilee Medal for her efforts to improve stroke care and outcomes in Canada, and internationally. She has received the World Stroke Organization 2024 Award for services to stroke globally. And so, Patrice, I'll hand it over to you.
Thank you so much, Krystina, and everybody for all the things you've shared so far, Anita and Karen. It's been awesome. You can hear me okay? Can you share slides for me, Krystina? Do you have my slides, or do you want me to do that at my end?
If you can, I can pull them up if you'd like.
I've got them. As long as it works, I think I'm good.
Yep, that's fine.
There we go. Is that okay? Everybody got it?
Yes.
So thank you, everyone. I'm going to talk to you a little bit about knowledge translation and co-production, a little bit of a different twist on this conversation, but building certainly on what both Anita and Karen have shared. So when you look at the knowledge to action cycle, Anita's talked about all her work with Ian, so this all comes from Ian Graham's work many years ago, and it's still, I think, an excellent model that really shows all the different stages. So Heart and Stroke's unique because it's a health charity. And you don't often think of health charities being involved in co-production, in research, but we're one of the biggest funders of heart and stroke research in Canada, next to CIHR, and fund millions of dollars every year. So we're not just the funders. We believe it's really important that you don't just hand out the money, but you set some expectations. And it's really important more and more as this concept of co-production and co-development arises. Where is the role for us? We can't be named, interestingly, as co-eyes on grants coming to our own organization, but certainly for grants going to any other organization where Heart Stroke's not funding. But once we do give out money and award grants within our organization, we then want to become involved. Now that all the conflict of interest stuff is over with, we want to become involved and help support the research in whatever ways are appropriate. And not just ourselves and our staff, but we also want to be involve people with lived experience. And it's, when you think about the knowledge to action cycle, it's not just in the discovery phase, the writing the proposals and getting the grants. It's then actually the carrying out of the grant research, but then all of the knowledge translation that comes after that. It just doesn't stop when you get the money or when the project's finished. That's when the real work begins of sharing that knowledge and getting it into practice. I've known Ian for 40 years, and he's been a huge mentor of mine. And his first words to me were, it takes 15 years between the end of a project and getting into practice. I'm like, Ian, I'm going into this whole world, this is my career for the next 40 years. I'm not going to spend 15 years doing this. So part of our guideline work has been really that rapid translation, not 15 years, but, our goal has been no more than 15 months. And so when you think about all these aspects, it's so important. And as I talk about that, when you think about it, I don't expect anybody to see the slide, but from Heart and Stroke's perspective, we have many levers we can use. We engage people with lived experience. We run major advocacy, as well as funding research. We do quality improvement and put out data. We work directly with clinical practice. And most importantly, as the others have said, and Karen said this really well, is the importance of bringing on partners. Building on people's networks. So whoever you're working with, build on their networks, bring in new partners to help rapidly share. And that's part of the co-production is everybody at the table has skill sets, have their own networks, and have their own perspectives. And, co-production, co-development is really about capitalizing on all of those. Nobody owns this by themselves anymore. Research is changing so much that we don't each own it. So think about health charities, think about patient advocacy groups like Heart Hub and others in the production. I'm going to focus now very specifically on a model we've created. So guidelines and the stroke guidelines I'll talk to, but I sit on, I think, 11 different guideline groups across the country and internationally. They're a major knowledge translation. And as I just mentioned, a way to rapidly take emerging evidence and get it into practice without waiting 15 years or even 5 years. Some guidelines only update every 5 years, but we built processes. So part of co-production is working with researchers to understand the results of their research, whether it's positive, negative, or indifferent. Like negative studies are just as important when you're writing guidelines. And what we've done is it's so important not to just write them from the scientific perspective, but to engage people with lived experience. Some of them can't read the science and understand it, and we don't expect that. But we need to marry that with the lived experience. Like, they'll tell us, and they're the ones we engage with are very vocal because that's why they're there. It's like, that's great. The science may say this, but I've never seen that in practice. I've been in the hospital, didn't get any of that. Really wish somebody had done this. So we can merge those, integrate those personal experiences and the voice into different parts of our guideline development. And we share that information back and forth. So, here's a quote I'll just let you read from one of our people that's been involved. We call them our CCRPs, our Community Consultation Review Panels. And it's a group of about 8 people, caregivers as well as people with lived experience who've had experience of a particular area. That's the focus of a guideline. And they meet at the same times as the scientific group, but in different groups. Back in the old days, everybody had their token person with lived experience or patient at the table. They ticked a box. That person was always intimidated, never felt like speaking in the meeting, would call me afterwards, oh, I didn't get to say this. So we decided to separate them out, but have their information leapfrogging back and forth. So 1 week the committee would meet, and then the next week the CCRP, and we say, okay, here's what was talked about. What is your opinions on this? And then we bring it back and forth. And it's worked really well for us. There is a publication for those who want to learn more. The other part is that we engage in for co-production is in those knowledge tools. So the guidelines are a tool for health professionals, but we also then translate those into for the lay public and for people with experience. And here's an example. This is a really important document that we're so proud of that we did last year, and it's just about to be published, is we worked with people with lived experience of vascular cognitive impairment when we did the guideline update and had them do a journey map, but not just I went from inpatient to rehab to this place. It's not a settings journey map. It was an experiential. Here's the struggles we had, the things we encountered, the barriers, the challenges, and the enablers at each stage. And then we turned that into a knowledge translation document and integrated all these pieces and addressed them throughout the guideline. And this has been, a huge piece. We've presented it out. And this was, by patients, it was great because when we took it back to the scientific community, they wanted to change it all. And we said, no, certainly you can have your input. We'd love to hear what you think. But we're not reorganizing or changing this because this is a lived experience journey map. And it's got to be, it's interpreting your research and putting it into their context. So we can't take their voice away and replace it with yours. Took a few battles to get through that one, but I think it's so important that we look at our co-production, not just knowledge users, but some of our knowledge users are people who've been through the medical system, and we need to listen to them more. And so I think just finally, we have lots of resources that are all part of our knowledge translation package. So as a health charity, we can really promote your research. That's our role as knowledge users and collaborators, to get it out there, to share it in all kinds of formats, and to work closely with researchers. So I think I'll stop there, Krystina, and turn it over to you.
Sure. Thank you so much for outlining that for us, Patrice. Now, one thing that struck me at the beginning of your presentation was that the call of really wanting to be involved, right? When you are named on a grant, you are wanting to be involved. And so would you be able to describe what those expectations are regarding what the expectations around roles and responsibilities when you are named as a co-applicant or collaborator on a grant?
For sure, and thank you for that. One of the interesting things I've encountered over many years of doing this is coming from a health charity. Heart and Stroke's the biggest health charity in Canada, and it brings some credibility and power. So everybody wants to name us on their grants as knowledge users or collaborators. But what I found over the years, they do that, and we never hear from them again. It's like, yep, they've ticked a box, they put us on, it looks great, they get the grant, we never hear from them. So now we're being a little bit more judicious. We have so the different levels now, when you think about it, are just a straight letter of support. Yes, you want Heart and Stroke to say, yes, we'll support this research, it's great. Give you that letter of support. But when we're asked to be a collaborator or knowledge user, occasionally co-investigator, we really stop now and say, well, what's our role? We don't want you to just put it on because it looks good at your end. But if we're going to do that and put our names on it, we want to have a meaningful role. So really now we're starting to have those conversations much earlier. Is it just at the end, some of the examples I showed you, by integrating it into our materials on our website and our information? Is that the role you want us to play? Do you want us at the table? Are you setting up working groups or subcommittees? Do you want us at the table there? Because we can contribute. People just think we're not just a health charity. I mean, we have a lot of people with professional degrees that work for us in all kinds, in a whole range of, as I showed you in that big circle, advocacy and policy and, as well as clinical and systems. So it's important for being a meaningful member, not just a token box ticking and getting, make it look good on the grant. We want to be involved in a role that makes sense, and we need everybody to start having that conversation earlier to clarify that up front, so those expectations are set. And if there is no meaningful role, then maybe just a letter of support is all you need.
Right. You did mention as well, at times it may be the role of being really involved in co-producing what those knowledge translation products are at the end of the grant. And so might you be able to provide some examples of how the Heart and Stroke as a knowledge user has co-produced these knowledge products and has really contributed to that knowledge translation and impact?
For sure. And, so when you look at some of the studies like Pure and Pure Mind that we've been involved in, that's for all this cognitive impairment. We've actually created a whole guideline just focused on vascular cognitive impairment, and have several knowledge tools coming out of that are in journal right now. We're just waiting for the final paperwork. We've worked closely with Jean Rouleau and the Canadian Heart Function Alliance that won the big heart failure grant that we were contributing to. Once the grant was set, we joined several of their working groups and advisory committee and their senior steering committee. So when they're trying to do different projects, we're able to mobilize many of our people that have experienced our own networks. And there's been lots of co-production of knowledge tools, knowledge surveys, and even things like surveys. One of the things we did with them is a national survey of every hospital in the country and what services they have available for heart failure. And that data and that's part of collaboration and knowledge using, is generating that data. And that's become a foundational piece for many of their, letters of intent and their research projects going forward, is having that real data to use. So that's another aspect of it.
Yeah, wonderful. Well, thanks for outlining that as well. I'd like to invite Anita and Karen to join Patrice, and we'll open up to a larger panel discussion here. We've talked a lot, and Anita, you provided really nice examples of the benefits and of co-production. But would you be able to share with us some of the personal challenges that might exist to carry out co-production successfully?
Sure. That's a great question. I think, of course, time, because one of the things that is quite important, and maybe you've already picked up on this by looking at some of the diagrams that Patrice has presented, is that co-production takes a lot of time. And even thinking about some of the examples Karen has provided in terms of how to make environments more comfortable and materials more relevant. So there's always the issue of time, and along with time, as a researcher, there's the issue of making sure that somehow the activities that you're involved in are recognized in your personal journey in your career. And maybe talking to some senior individuals who are involved in co-production and trying to understand how they can be represented on your CV or your resume. And I would think that, like, for the knowledge user, in my experience, that sometimes with knowledge users who are involved in your projects, sometimes they face issues within their own organization to justify their own time, and trying to understand as a researcher how you might be able to help them help their own organization, how they can then go back to their organization and demonstrate value in terms of contributing to the work. And that may not happen at the end. In fact, it can't happen at the end of a research project. That conversation has to be happening throughout the research project. How can you make sure that your knowledge user is also satisfying any kind of needs that they might have in their own career as well?
And I'm sure the challenges don't only occur at the individual level. There are challenges as well that can occur at the team-based level. And so, Patrice, would you like to jump in on maybe some of the challenges that you've encountered working with researchers?
Sure. And I think, part of that is just, as I've said earlier, is understanding the roles and responsibilities. And, with our teams and interacting, we're probably during grant season, probably send out at least 24 letters of support, and are involved as knowledge users on at least 12 grants every cycle. So as Anita said, time management, be careful what you wish for. So if we're asking to have more meaningful engagement and not just be the tokenism, then we have to make sure that we're planning and have capacity, and that the things that we identify as those roles are appropriate. And so I think that's the biggest challenge is A, being in scope, B, who's going to actually be the person at the end of the day who gets called on to be involved, and do they have capacity, and where is it appropriate? It's not always appropriate for us to be involved. So it's really understanding, and, to be blunt about it, is what is the value and impact for Heartstroke? If we're going to give up our time and staff time, it has to have some value back directly to us, not just for the researchers, right? And obviously, most of the research does affect us in some way, but really understanding where that impact and value is.
And if I might add to that, I think it's
Yes.
also understanding and having the conversation about that impact and value, even if the research findings don't show a huge effect.
Yep.
They might be so small that you can't justify any change, but how might that in itself also help the knowledge user?
Yep. Because knowing that it's not some dramatic change is important too, because especially in our guideline world, you won't put something in guideline, everybody should do it. It'll become more of a conditional, if the sun is shining and it's Tuesday kind of statement, as opposed to, even though the effect is so small, hey, everybody should jump on the bandwagon, because that's when you get a ton of pushback.
One thing that I've observed myself in my own career and involvement in other groups as well, is that the readiness to collaborate or to partner with knowledge users falls along a continuum for researchers. You know, some are really keen, they're already embracing the approach and doing a fantastic job doing it, while others may not feel ready or may not really see the relevance in doing that type of engagement for the type of research that they are engaged in. And so if you could leave our audience members today with one actionable step that they can take to engage in meaningful research co-production, what might that step be? And Karen, would you like to start?
Sure, Krystina. And I think for me also, and actually, I just read a couple of days ago a very interesting article. It's from Canada, actually, so I will make sure to share that link with you after the webinar. But it's really about recognizing patient knowledge is a first step toward partnership and value creation. And I think if we take that concept that, you know, like if professionals have expert knowledge acquired through learning about medicine and science, and of course, maybe their clinical practice, patients acquire that expert knowledge through learning about their conditions, their treatment, and experiential knowledge through life with their conditional self-care. So I think acknowledging that also help us understand the value that knowledge users or patients in this case can also bring to the table. And again, for me, I think really tapping into that network, maybe that is through a patient organization, for example, because that's something that I have also, you know, like in some interactions that I have had with researchers. They have told me like they haven't found the patients or the right amount of patients on a certain condition, and then I'm like, okay, it's really a lot of the time it's really knowing your stakeholders, thinking outside the box, maybe reaching out to a patient organization to try to find those patients might be better. You know, like you might find more patients in that way. So I think, you know, like, and also acknowledge that this is really relevant, and I really applaud the efforts that researchers make to involve patients.
Your response highlights, Karen, that it's certainly not the intent for knowledge users to assume the role of traditional researchers or to be experts in research methods. It's really about contributing that distinct knowledge that they are bringing. And so, Patrice, would you like to offer your piece of advice?
Yeah, and actually it perfectly builds on Karen's. And as you just said, Krystina, they bring their own advice, but you know what? We should take the time to train as well. There really should be a component of training involved. So they bring their own knowledge and experience, which is so awesome, but they don't know how to express it, and it intimidates them and makes them feel uncomfortable. So actually, in 2 weeks, we're doing a whole knowledge translation training day for people with lived experience, and not just on how to be part of a research PI team, but actually through the 4 components of, you know, being on a grant team, preparing a grant, being on a review committee, reviewing grants, so those lay reviewers, and then being on a guideline or a webinar such as this, how to be part of those, and then the advocacy and policy, how to be involved in doing advocacy and working on policy. So it's so important. There's some really good programs out there now through CIHR, through you know, CanTrain and that are developing these training programs. And we strongly encourage researchers to take the time in co-production to understand not just the knowledge, but the learning needs of their collaborators and knowledge users, and address that.
Great. Thank you. And Anita, would you like to offer your...
Sure. Well, so I haven't got it quite solved yet, but when we were more in person, I would put a lot of stock into trying to make sure there were longer coffee breaks so people could kind of get to know each other on a team. And I think that's really important for the ideal functioning of a team, just getting to know people a little bit better, getting to know those common points of intersection. Oh, we both have dogs, we can talk about dogs, that kind of thing. but it's harder online. So this is what I mean about I haven't quite got it figured out yet. So one of the strategies I do use is trying to get online just a couple minutes early and having a chat with whoever else is on there a couple minutes early, having that social chat and making that space for someone to maybe ask a question as well as the social chat, ask a question about something that related to the research that they may not want to ask in the formal meeting. So when I say I don't have it worked out, that's one strategy. And I'm still looking for other online strategies to build those kinds of relationships.
That's great. There's certainly value in not having that structured agenda as well, and in allowing the conversation to go and being able to build those common interests and the sense of belonging amongst the team. So excellent. Well, I'm just going to jump into, we have some questions that have been posed in the Q&A. And so I'll start with this first one. So for those who may be concerned about possible problems that can arise when involving patient partners, have there been any strategies put in place to mitigate these problems or resources made available to team leaders to manage any possible problems? So thanks to Anne-Marie for that question. And I wonder if there's anyone who'd like to take that one on.
I think one of the key aspects as well is to have a professional moderator, or someone moderating who also has that expertise. Sometimes having a psychologist or a sociologist might be really good to also manage, also the different issues that may arise, or different personalities, or someone maybe trying to, it's always, or sometimes like that power balance that you need to manage.
And I think building on that, the other piece is, I'd mentioned the training, but it's also doing prep work. So we do onboarding, where we take the time to have those one-on-one conversations to really understand the person, where they're coming from. It helps us pick up some biases or personal agendas they might be bringing to the table. So if you take the time to do that in advance and do your background prep work and have those conversations with them, it helps them feel more comfortable when they're get together. And building on Karen or Anita's comments about taking that time to get to know each other in the bigger group, but it also helps you later know what to anticipate, and also give you a chance to tell them, when you're doing the one-on-ones, what the group's about and where sort of the areas that we won't go into. So give them a bit of boundary, because that's okay to give them some boundaries. But to do it in a respectful and, not in front of 20 people, but take those one-on-one times. It really does make a difference.
Yes, for sure. There are other questions in the Q&A, and I'm sorry we're not going to have time to address them during this webinar here, but we will take note of them and address them as well online if there's any that we can with the recording as well. And so please keep an eye on that. We will do our best to address what's been proposed. So thank you for everyone for attending. We have just under a minute left, so I'll wrap things up. I really would like to sincerely thank our panelists here for their time and their expertise here today. I certainly got a lot out of this discussion, and I really appreciate all of you being here today. Thank you as well to those who are in the audience. I hope this was valuable to you as well, and I appreciate you spending time with us, the BHI. So if you have any comments or questions following this webinar, please do not hesitate to reach out to us. And otherwise, I'll leave you to the rest of your day. Thank you.
Thank you, Krystina.
Thank you, everyone.
Thank you very much. Goodbye.
Bye-bye.